All right, folks. So we'll start tonight going the face and neck issues. Let's get this. We know so the recognizing nosebleeds. I hope we don't have to say that we need y'all to figure out how to recognize this. I'm pretty sure that y'all could at least notice one. Let's see. So trauma to the face and head is going to bleed. I use the old analogy like a stuck hog. The face is very venous, so there's a lot of veins to the face. Um, Adults and children alike, it will bleed pretty profusely. Men, I'm sure you've all cut your faces shaving and you understand it bleeds a lot. Ladies, I know y'all have cut your legs and all that, and you've kind of had the same thing. But at the same time, as you just got to think, it's you're gonna look more dangerous than things because of the amount of bleed. It will bleed pretty profusely because it's it's so venous. Sorry, I'm trying to answer text messages. So any sort of trauma and all that to the face is going to be super super rough because you're going to be like, oh my god, there's amounts of blood and all that. So the biggest thing is when you recognize any types of trauma to the face is cleaning the face off to actually realize and see, okay, that's where the injury is. What really is a life threat versus what is okay. We can put a band-aid over that. You all have seen UFC, boxing, and all that. They get very bloody when they bust their face, especially the eyebrows. It's a bad place and it bleeds. You can't. It's hard to stitch in those areas. It's rough. So we uh we recognize those. We bandage them. We'll go over any types of penetrating neck trauma, some larynge. Let's see, spine trauma. We shouldn't not talk about that. I mean, it'll be just tad bits about that. Um, so we'll go over facial trauma, skull fractures, foreign bodies in the eye, which I've gotten to be very familiar with those out here. We get those very, very often. Dental fractures. I don't like dental at all. Really despise messing with eyes for a long, long time, and then everything I hear, uh, it has it's gotten to be where eyes now don't bother me near as bad. But teeth still, I despise messing with teeth. So the face and the neck are particularly vulnerable to injury because of their relatively unprotected positions on the body. So trying to say that there's nothing there to protect it besides your flinching, your reactions, your time to recognize that something's going to happen when you throw your arms up. Arms and hands are there, but sometimes your reaction times may not be there. They Some injuries will be pretty dangerous. Some will be life threatening. You may have an open injury. Let's say if there's a penetrating wound to the neck. Uh, so it's one of those with the penetrating issue to the neck that you may turn around and have an open wound, and you may start sucking in an air embolism. You have to be careful about that. Recognize that early, and uh, close that wound, fix it, stop the bleeding. That's a life threatening. Let's fix that now. Let's move forward and see if we can keep that air embolism from going any further. So the head is divided into certain areas. So you have the cranium, obviously is the brain. It's also referred to as the skull. The most posterior portion of the cranium is called the occiput. I probably did not say that right because it just caught my out the corner of my eye. I was like, that didn't sound right. But each side of the cranium, you have your lateral portions are called your temples or your temporal regions. Everybody knows about where those are because you know where your normal temporals are. The forehead is the frontal region. Um, and then the anterior to the ear is the temporal region. You can feel the pulse, the subfiocial temporal artery. And then you know that there's a picture that kind of helps that a lot better. So on this side is nasal bone. We talked about this before. You have your zygoma, your maximal. All of these I have seen broken. I have seen this broken. I've actually been able to see pieces of the skull missing, and then I haven't done it, but if you wanted to, I could actually put my finger and touch the brain itself. So all this is very, very vulnerable. Anybody that has a maximal fracture is very, very painful. A lot of times they're loose fractures because you got to remember they're just skulls. So if it breaks, there's nothing that's hanging onto it. So if it breaks in this region around here, this part may hang a little bit lower, and they're just constantly like, oh, it hurts in that area, and you just don't know why. Obviously, you have two zygomas maximals, one nasal bone and a mandible, because it has on either side. So that's where you have two of those. Next, so the bony orbit protects from the eyes, composed of the lower edge of the frontal bone, the zygoma, the maximal, the nasal bone. So it has an occiput. It has an area where the eye it holds the eye in place. Now the eye can be popped out, the eye can come out of socket. It just depends on what type of trauma. It's one of those that even if it does pop out of place, I've seen that they've been able to replace them with the eye itself. And then obviously if it's bad enough, if there's optical trauma, they'll be able to replace the eye with a false eye. Let's see, only a proximal bone of the nose is formed by the bone. Let's see here, let's show this picture. So your mandible, here's your temporal joint. So look, that's where your hinge is. Where your jaw opens, it flings this way. That's the only point where it hinges. The occiput, your pinna, that's the bony part of the ear. And then your 7 cervical vertebrae. Those are kind of important, so you may be able to know where these are for test purposes. The exposed portion of the ear is composed entirely of cartilage, which we know that. We've seen those before. The pinna, the targus, and the superficial temporal artery. Now, I'm not up to standards and speeds on things, but don't people get tragus piercings? I'm not, like I said, I'm not a piercing person, but I want to say I've seen these as a piercing spot. I'm not asking anybody to answer for sure, but it just rings a bell. Let's see here. About 1 inch posterior, the external opening of the ear is the mastoid process. The mandible forms the jaw and the chin, which we should know that by now. That's the anatomy of the body. So the neck contains several structures. So it does support the cervical spine. It gives it its rigidity. It gives its muscle, so we're able to hold our head up. The human head on average weighs about 8 pounds. So if we weren't able to have the neck muscles, the cartilage, the bones, our heads would just like lay down on our chest, our shoulders, because the bones are straight and fixed and all that, but you got to think that flexibility is held by the muscles, so we have the support in our body structure. The first 7 vertebrae of the spinal column is C1 through 7. The spinal cord exists from the foramen magnum and lies within the spinal canal formed by the vertebrae. We talked about the foramen magnum before in several other chapters. The upper part of the esophagus and the trachea lie in midline of the neck. So when we say is the head midline, what we want to make sure is if you're standing at the head of the body and you look down, that their nose is in the center of their body. If for some odd reason, if it's off to the side or one side or the other, like if their trachea, here, I'll show you this picture. So if their trachea right here is not midline, means it's shift to one side or the other, there's some trauma. And most of the time you have midline shift because there is a hematoma or pneumotoma that's pushing it over to one side. Oh, sorry, I don't know. I didn't know I could change sides like that. But most of the time, something is down here is pushing this over and it's causing it to not be midline no more. So make sure you check if you're doing a trauma assessment and they're having types of breathing problems, just make sure you look at this line and make sure it's midline. That's what we want to see. Make sure that's the most part right there that's important. The Adam's apple is located in the center of the anterior of the neck, which is important. That's what we have to make sure on the men that is there. The other portion of the larynx is the cricoid cartilage. Here's a better picture. What the cricoid cartilage does is it forms a rigid cartilage below the thyroid cartilage. So here you go. If you've never knew this, so here's the Adam's apple right here. Makes that niche. So if you look right here, this is the cricoid membrane. If everybody will look to the ceiling and you kind of feel that structure in the center midline of your throat. Here, I'm gonna show y'all so y'all can pay attention. You have to excuse the glasses tonight. It's just not feeling it. So right here, if I look straight up, there's my Adam's apple. If I go right below it, you notice how my voice changes a little bit. There's a soft spot right there that what we want to do, I don't know if y'all can see that, but it is like right here below my beard line. You'll feel your Adam's apple, and then you'll go right below. So that little area right there is what we can do for if we have to do a surgical crite. Y'all have all seen it on TV where people do surgical crites and all that. That's the area that they cut through. They'll cut through there, and they'll you've seen them. Oh, we're gonna take a pin and do. It's not big enough. They teach us to use a 14 gauge needle. You have to remember the size of a 14 gauge needle. Most of the time, for just average look, you can say that's the size of the top of your pin. So you can imagine how much air you're not going to get through there. So it's very hard to breathe through there. Some states do not allow it because it's outside of, it's a surgical procedure. Sorry, Brandon, the other instructor's texting me. All right, got Brandon situated. All right, so again, that's where we're going to put it. Again, it's not going to be sufficient enough, but we're still moving air up and down inside the body. If we have facial trauma and we're unable to get it there. So let's get rid of this. Why is it showing? I don't know. So the larynx or the trachea, it's below the larynx, so you can know your anatomy of where things are going to be. The trachea connects to the oropharynx, and the larynx, I'll say, within the main passage of the lung. So one either side of the lower larynx, on either side of the lower larynx and the upper trachea lies the thyroid gland. The Sternocleidomastis. Somebody want to try to pronounce that better than me because I just badgered the crap out of it. The muscles. So originate from the mastoid process of the cranium and insert into the medial border of each collarbone as the base of the base of the neck, and it allows the movement of the head. So you'll have the you have your muscle. So it's not coming up. This has a picture. So that's where your muscles will start to fix, and you're able to move the head for the face, and you move forward from there. Trying to get other classes situated is kind of rough right now. So once we kind of understand how the neck is built, we have our structure of the neck, where the muscles lie, where our midline is. We build better ideas on how to fix things. You know, you have your arteries running down each side of the neck. Those are major and important, so we know the placement of those. And now we move to the eye. Some of the worst things that I despise doing is eye, because it's just one of those that sucks. Messing with the eye is not fun at all. you have, and the reason why I don't like eyes and haven't liked eyes is you just have two of them. They do kind of, they are very particular about holding debris. Um, where the problem comes in line when you have to be very cautious. So the eye is a globe shape. You see on yours is about a 1 inch diameter. It is located within a bony socket, so you notice your sockets around your eye are all bony. That gives it its structure, so it just doesn't go anywhere. It's composed of adjacent bones of the face and skull. The orbit protects 80% of the eyeball. Between and below the orbits are nasal bones of the sinuses. So, uh, so now that we have your sinus pressure, you'll get the swelling around it here. You'll feel it in your eyes. Your eyes get situated too because it's all pressure built in there too. The pressure is built around here, so you'll get you'll get the nasal, the optical pressure from your sinus impactions. You'll get it right in here. You'll notice the swelling in your face. It's sinus season. Bailey, you're right. It's the eyes are just weird. So we have some cool stuff. I really wish I could show it to you. If I had somebody in the clinic, I would show you. So we use a dye that dyes the eye, and I may actually do it to myself so y'all can see it. So it dyes the eye, and anything that's in the eye held underneath a black light shines. Becca, I've seen my cat and dog eyeballs pop out due to trauma. Yeah, see, I don't like that. I don't like that at all. It's pretty cool with these. So if I have a debris in my eye and I dye the eye and I turn all the lights out in here and then I use the black light, it shines. So like, I'll probably do that for y'all. I don't know. I don't like doing it because it tingles a little bit. So so here you just need to know parts of the eye. You need to know that where your lens is, where your pupil, your cornea, your iris. Those are important because if you have, yeah, we do have the Florentine eye stain. I don't like it. So if you know the damage of where these are at right in here, it helps you when you pass on. There's no difference in treatment because treating this is all going to be the same. It's really not much we can do for it. We just go. Most of the time, we get debris, it's going to be on top of the cornea. If it gets embedded or it's been there longer than 8 hours, we can't remove it out here. We do have the magnets, we do have the loops and all that, but the eye is just like the throat. The more you start messing with it, the more trauma it creates and it starts to swell. So what we try to only do is mess with it once. We can't remove it. We send them in. It's not the best thing in the world. If I don't feel comfortable in trying it, I don't do it. I send them in. We've had some people go onshore. They got to the doctor, to the hospital, got it seen, got it checked, got it out, and they returned to work 2 days later. Man, I'm sorry I couldn't do it. Because I don't want to cause any more trauma. I don't want that piece of debris to be pushed any further into the cornea or get inside. The lens is not possible, but you could potentially get it on the inside of the posterior chamber. That's the issues we worry about. The artery, so like when the doctor gets super close to your face and they dye your eye and they want to look, they look all the way back here to the artery and the optic nerve to make sure that there's no damage to any of these layers. You see that the layers are here and that's a cut down view, but they checking all that out. So they'll look up and down and they'll move around. They just don't want, they want to make sure that there's no damage back here. So that's what the thing is so close in your face for. Sorry. So the learning about the eye to me is pretty cool. I don't like messing with it. So the clear jelly-like fluid near the back of the eye, it's called the vitreous humor. It's not funny, I promise you. It's cool. So the eyeball or globe keeps the shape as a result of pressure from the fluid contained within its two chambers. In front of the lens is a clear fluid called the aqueous humor. So when the eyeball does rupture, you can have a gloop amount of fluid, like a kind of like a gel type. You can have it'll be like a very runny egg. Um, I've I've seen it and messed with it. I've actually had one that their eye ruptured, and that we basically kind of swept their eyes up into pieces and sent them on their way. It was just, now they had some massive trauma and they died due to other reasons, but I don't do no eyes. That's for the new guy. So if you look here, the conjunctive is the membrane that covers the eye. And you have the lacrimal glands that often, so right in here of these ducts, you will get a lot of debris right in here. So the lacrimal gland is up top. So, and then on the side, you have your sacra, the white part, and the conjunctivity is the pink part. So out here, what we'll do is we'll lay a Q-tip on top of the eye, or one of the Q-tips with the long stick with one end, and we'll flip the eye. Where's my finger? So we'll flip the eyelid. We'll check the underneath. We flush the eyes very well, and so we flip it, we flush it, we take the Q-tip, we wipe it, and all we do on the bottom side is just pull it down the same way. We run it with the Q-tip, we flip, we wash it, we dry it again, and then we add the fluorescein. So that's cool and all that, but again, it's one of those you're like, I don't like it, I don't want to do it. A lot of times you will see here, if the patient has had debris in their eye overnight and they wake up and they come to you and you're like, Doc, something's in my eye. Well, their eye's already swollen shut. I'm not really gonna mess with it because it's already a traumatic issue and I can't fix it. So you'll notice right into here in the ducts and the nasal ducts, that's gonna be swollen in that area. There'll be a lot of like the morning booger, eye booger stuff. It'll be like right in here because the eye's trying its best to get it out because it knows that there's something in there. Y'all have all been there, you know, we have those issues that we just can't get things out. Or if you wake up and you're like, why is my sinuses or an infection in my eye? Why, you know, what's the deal? So the sacra is a white fibrous tissue that helps maintain the globular shape. On the front of the eye, the sacra is replaced by a clear transparent membrane called the cornea. This allows light to enter, and the iris is a circular muscular behind the cornea. Trying to drink more fluid so I don't yawn in front of y'all again. So the pupil is the opening in the center of the iris, right dead center. This allows light to move to the back of the eye. The lens is behind the iris. The lens focuses images on the retina at the back of the globe. The antichoria is a condition in which a person is born with different sized pupils. So you can also make sure if you look at somebody and this pupil over here is really big and it's blown. This one's really small. You need to double check to make sure that they don't have a birth defect like this one versus is that result of head trauma. That'll tell you too if there's been an overload of pressure or contact with the face if you can't tell just yet, and the pupil swells and then it's blown. So then this one will be normal. That's indicative of a head trauma. So the retina contains nerve endings which respond to light by transmitting nerve impulses through the optic nerve. Sorry, I just found out from a nurse friend of mine there was a bomb located at our level 1 trauma hospital. They blew it up in the middle of the road. The retina is nourished by a layer of blood vessels between it and the back of the globe. So it is very, I mean, obviously, you know, when you take a shower, you rub your eyes or get something in there, it gets, the eye fills with blood pretty fast and you see it. So yes, you can have blood and all that in the eyes. You can see at the bottom, the retinal detachment is when the retina detaches from behind the underlying cryoid and causes blindness. Now you can have a detached retina and still see that requires emergency eye surgery, or you can have a complete detached retina from, let's say, massive trauma or a head injury, and you lose your vision completely. Oh, I gotta see this real quick. Hmm. All right, that was weird. Um, so injuries to the face and neck can often lead to partial or complete obstruction of the airway. So when is the only time that we remove something from the face? Anybody remember?
If it's, oh gosh, it's at the tip of my tongue. I keep wanting to say if it's affecting the breathing. In the mouth. Yeah. In the mouth. Okay.
Yeah. So that's the only time that we're allowed to remove it if you notice it starts to affect their breathing. Several factors may contribute to the obstruction. You can have blood clots in the upper airway, which we don't want that. We don't want it to go down. We want it to come out. Direct injuries to the mouth and nose and larynx. We've learned before that Kobe likes to drink his own blood when he gets a bloody nose, but we lean forward now that we know that. You pinch it, leave it forward. Just messing with you. Direct injuries to the mouth and nose and the larynx. I'm trying to make sure you're paying attention. That is significant bleeding, and you can affect the respiratory compromise because of the amounts of blood. Injuries may cause teeth or dentures to become dislodged in the throat. Again, we want to remove those as much as we can. We want to try to bring those to the outside. We don't want them to be swallowed. They can be replaced. I mean, dentures, I'm sure you can just buy some more. But if it's your original teeth, I'm sure that you would want those to be replaced with the original ones, if possible. But again, we don't want to put any foreign objects, debris in our stomach or in our intestinal tract. So we want that to go forward. We remind them to lean forward. Breathe in your nose or out in your mouth, out your mouth. Don't try to swallow anything. And it's okay if they constantly spit. Give them an M&S bag and allow them to spit it up. Because at some point you're going to be like, well, how much blood did they lose? Well, there's the bag. It's yours, bruh. You are going to have lots of swelling. Just because it's because of where it's at, it's going to swell as fast. Y'all know facial injuries swell. The airway may be affected when the patient's head is turned to the side. If you get to them and they're already turned like this, that may be something that's caused the issue. Maybe they have necking issues. Possible injuries to the brain, cervical spine may interfere with normal respiration. So if there's traumatic brain injury or there's a bike wreck and they have contact of the head to the concrete, that may be part of the reason that they're having trouble breathing in the first place, is because of the bleeding and the potential swelling. So remember that also. Soft tissue injuries to the face. The face and neck are extremely vascular. Swelling in this area may be more severe. Skin tissues that will have rich blood supply, and blunt injury can cause a hematoma. As you see in this young man on this TV or on the screen there, he probably slipped, tripped, and fell. That's probably what happened to him and struck his face. He could have hit his eye. We don't see any other trauma around his face, but what gets me is this right here happened in his temporal area, and it may be at the corner of his eyebrow right here, probably the low corner of the eye, but that's close enough to the temporal that could potentially cause some severe damage. We want to make sure that we insist that they get that CT, MRI of that area. Obviously, they're going to, because of it. That's going to be a traumatic area. There's not a lot to protect your temporal area. It's very soft, fragile bones in that area, so that's why CT, MRI is going to show if there's any other injuries there. Dental injuries, the mandible injuries are common cause of its existence. Secondarily, the nasal fractures is frequently. Most of these fractures are a result of vehicle collisions from them hitting the dash, the steering wheel. The seat belts are locked, but they were able to go forward and strike the dash of the vehicle or the steering wheel. Signs of mandible fractures is when they have a jaw and it's like this, and they open, and it's a constant curve. Now, I'm not talking about the overbite or underbite. They have trouble, and they're like, I can't follow a tear. It's just really numb through here. And then, like it says, there's the inability to open the mouth. So, and they smile, and their teeth, it's offset. It's like this. They can't. They constantly just sitting here trying to rub it. Maybe put it back into place, which is not going to happen. It's going to be messed up. So maxillary fractures. You'll have massive facial swelling. The face is just unstable. So when you go to palpate the face, detail it, when you go to feel through here, it's just it wiggles. It's a structured jello, if that makes sense to y'all. So when you go to feel through here and you check the jawbone, the mandible and all that, and the maxilla, it just feels like it moves. It's weird. The first time you're like, what's wrong with your face? I don't know, but I don't like it. Okay, so and we talked about the misaligned teeth. Teeth fragments can become in the airway. We know that. We're going to try to remove those and or spit them out. So I'm not going to read that screen over there. It's the same patient assessment every single time as you go up to them. You want to check your MOI. Is it from a collision, a fall, sports activities, penetrating trauma, blunt trauma, what type happened? Check your ABCs. Look for your injury first. Is it immediate or life-threatening? We fixed that initially. If we have life-threatening hemorrhages, let's fix it. Now, obviously, you can't put a tourniquet from here up. We may want to do that to some people, but it's against the rules. You can go to jail for that. So sorry, it's taking my headphones. I highly suggest that you try not to tourniquet from the neck up. Some people need it, but we can't do that. From general impressions, what I want you to look for is serious injuries. What looks wrong with Fred? What's your problem? Why am I here? And then when he turns around, there's a big old hole in his cheek. Be like, well, there was some skin right here, but it's gone. So I've had one collarbone injury in 20 plus years, and the guy was running up the street carrying a car battery on his shoulder. I don't really know why. They not light, but he was running doing it. Those are very painful. The shoulders dropped and in an awkward position, it may be rolled forward. They're going to be very painful about that. Controlled loss, blood loss. We know that. We're going to look to figure out. I'm not sure, like a dislocated or a broken collarbone, how you're going to control, because they don't really bleed. It's just a bone that's broken. If you're able to, and if you're able to splint those, you put the arm across the chest in this position. You want to make sure that you have it in a position of comfort. You secure it with a I just went blank, like completely blank. Sloth and sling, sling and sloth. The I just went blank at the complete name. Oh, I feel like an idiot, y'all. Anyway, and you secure it with Curlex. Hold it, and if all you have is Curlex, make sure you go up and over, and then around the entire chest that holds it in place. Sling and I'm gonna aggravate myself until I remember this. So I'll keep saying that. Y'all don't worry about it. Check for responses. Obviously, we know our AFPU because we're gonna be trying to talk to them. Hey, I'm Chris with the ambulance service. Can you tell me what's going on? Obviously, if they're screaming, hollering in pain, their ABCs are patent. You can take that for advantage. A lot of times, if you're walking up and you see them talking to somebody, then you can go ahead and kind of skip that assessment because you know that it's working, it's present. Your pain there, I always ask them on a scale of 1 to 10, 10 being the worst pain you ever had in your life, 10 is having your leg cut off, What's your pain right now? Oh, it's a 13. All right, so you may cut both your legs and a half of your arm. I just want to make sure that we get this. Some people's pain scales are higher than others. A lot of individuals believe that if they say my pain is unbearable, that they will get to a bed in the ER a lot faster. That is not the case right now because of the pandemic. We don't have those. That ability is not there anymore. Airway and breathing. Now my deer camera's going off. That's really important, y'all. I'm just gonna let y'all know I like y'all, but these deer cameras are way more important. So decap BTLS, I want to make sure.
I said I understand.
Yeah, I'm watching two really big deer right now, and this one's actually just a little doe, but I'm watching two big deer. I'm waiting for my camera to actually upload tonight at 7. I'll get all 4 cameras uploaded. So if it's 7, we may be pausing for a minute. If the patient's responsive or unresponsive, that's your primary assessment. What is going on? Assess their quickly of their breathing. Do your decap BTLS and move on. Circulation. What's their skin color, temp, and condition? Is it normal? Is it? I just need to know your rapid assessment. Your rapid assessment should take about how long, people? Tell me how long the rapid and the detailed assessment should take.
Less than 10 minutes.
The rapid assessment should take 30 seconds to a minute because you're triaging them. That is a quick assessment of triaging. If it's only life-threatening, you can stop and fix it at that point. If it's not life-threatening, you want to make sure that you note it and you come back to it. So as you're doing your detailed assessment, you're like, okay, so I remember if it was not a life-threatening issue, I can come back to it in the detailed assessment. Transport decision. Do I need to stay and play? Do I need to load and go? What are my overall goal from what I had? My general impression, my primary assessment, my rapid assessment, my scene size up. What in my head is telling me, time to go, Chris, time to go, Chris. Or, hey, bro, we got this. Just, I'm gonna go get the truck, I'm gonna back it up. You handle your patient. I need to know that in about the first 2 to 3 minutes, how my patient transportation is gonna go. Do I need additional resources as I'm walking up to the scene? Because remember, it's easier to cancel them than it is to call them after you're like, oh God, I got 47 patients. I didn't see them. They're in a clown car. So remember, I'm not saying every time you go to a car wreck, dispatch, go ahead and send me another unit. Bruh, the car just backed into a pole. Okay, so the earlier you get there and you see your assessment and you realize, be like, 2 cars, 4 patients, they all want to go to the hospital. Dispatch, go ahead and send me another unit. And most likely, my luck, all 4 of them are going to go to a different hospital. So I got to call 4 other hospitals or 4 other ambulances. That's normal. That's a Chris Wally problem. Let's see. So my notes do not correlate with that slide. History is taken as the same exact thing as we've talked about before. What is your personal history? I want to know, do you take any current medications? Do you have any allergies? The last time you eat? It kind of sounds like I'm doing a sample, right? Okay, so do your sample that builds your history. Obviously, we know by this point if they're responsive or not. We can get those information from them. So your physical exam, this is what's going to take you longer. This is going to take your more detailed assessment. I'm going to decap BTLS. I'm not going to stop because of a broken leg and it's non-traumatic during my initial assessment. This is also not going to delay my transportation decision. If it's going to be like, okay, that looks like a really bad break, but I can splint that en route. Let's get him on a backboard. Let's get him on a stretcher. Let's go, sir. I'm gonna splint your leg once we get to the truck. If it's one of those you're like, this road is gonna be bouncy as crap on the way out, splint that before you leave. Put your cardboard split on there. Put you some pillows or blankets, to try to make that more feasible for the patient to go. And as a basic truck, guys, you're not gonna have those narcotics to give to this patient. I've always said when I was on the ambulance full time, and I rode the fire truck for a while, I always made my rookie EMTs ride in every call to the hospital with the patients, because you need to understand what those patients are going to go through. So when you get there, like, oh no, it's going to be a smooth ride, and you're like, how you know? Because you don't know. It's going to be rough. When you're on the truck and you move up to an FTO, I always make my EMTs, paramedics, or advances lay on the stretcher on the way to a call. Yes, you are running lights and sirens, and it could be the same way as you're going back to the hospital, because you get to experience everything that your patient is fixing to feel. We talked about that to make sure if you control your bleeding, control bleeding is maintained, and note the location of the injury. That way you can keep going forward, move things, catch it, note it, go on. During the physical exam, use both your eyes, your hands. I want to touch it. I want to feel it. I want to make sure that everything is in its right place. If it's in its wrong place, I should be able to tell, because I'm doing such of a good assessment. So being noted, if you're able to do that, that's during your detailed assessment. And assess all underlying systems, your breathing. You want to check their abdomen. You want to check their chest wall, their pelvic stability. Make sure that they can feel their jewels. Let them make that. Hey, sir, ma'am, I'm going to need you to make sure that your jewels are intact. Same thing. Do you feel like I need you to smile for me? Show me your teeth. That lets you know the mandibles, the flexibility there. Open their jaw. That range and everything's there. So that helps you build that assessment when you're doing everything. Secondary assessment is going to be continuing on. So the visual acuity is considered the vital signs of the eye. I want to know, hey, can you tell me, I do this in the back of the truck all the time. There's always a digital clock or a manual clock in the back of the ambulance. Tell me what time it is. No, you're looking only 4 feet away, but sometimes they're different colors. Or, hey, sir, can you tell me what's written on that sign as we go by? Ma'am, can you tell me what color your purse is? That gives you that ability to check the assessment. You don't have to do that every single time because of in the eye. Because if you see them moving around and reacting to you as you're speaking to them on the way to the hospital, or as you're doing your assessment in the back of the truck, or even right there on the scene in their house or wherever, that you may not have to. But if like they had facial issues and their eyes injured, do a visual acuity. At the same time as you want to know how far that they can catch something up to their side view, and then if they're having trouble tracking your finger across. Now it's not like I'm doing a DUI assessment on them, but I want to make sure they can follow my finger side to side if they had any eye issues. Vital signs. How often do we do our vital signs?
Every 5 or 15 minutes.
All right, so we do that for traumatic and non-traumatic. So we know those. You must be considered visible bleeding and unseen bleeding inside the back. We don't know what's going on the body. We have no idea to say, oh, look, they're bleeding in the abdomen. I can tell you, I got my x-rays on. We got this. Oh, look, I can't see it anymore. I can see it. So we don't know those. We have people ask all the time, would you think it's broken? If I knew it was broken, I really wouldn't be riding an ambulance. I can promise you. So you're like, well, from my training and, from my times out here, it appears that it could be fractured. I said, but I've been wrong before. I was married once and I was wrong before, and I've been called all sorts of names, so it's okay. I got that. Sorry, your picture. Um, so that being noted is we can always say we don't know, but it possibly appears. Um, facial or throat injuries, you got to be careful because that's the way your air goes up and down. Remember, big arteries for blood to go up and down to your brain, so that's important too. Make sure this area is much protected. When it says use use appropriate monitoring devices. So you tell me what is an appropriate monitoring device?
Blood pressure cuff, SpO2 monitor, pulse ox.
C-collar.
Yep.
I mean, things like that. That's what they're referring to. Because when I first read it, I had a lot worse of a headache, and I was like, monitoring the serve. What you talking about? And it made sense later it got in the day. So repeat the primary assessment on your way to the hospital. I want you to be off the scene as you're reevaluating this patient. You want to recheck the patient every 5 to 10 minutes or 5 to 15 minutes, depending on your category that you list them in. Because what you list them in may not be what I list them in, but you're the initial provider. You make that first triage statement and you move forward with that. Provide complete spinal mobilization to any patient with suspected spinal injuries. We've gone over this before. Depending upon what your local services protocols are, is how you treat them. Just because I tell you if they're standing, walking around, we don't board them. That's what my service does at home. Out here, if you had a greater fall than 6 feet, you're getting a C-collar at least, because they're going to bring you to me in a Stokes basket and on a scoop stretcher. So that being the case, I may leave you there, but you're going to be on the bed and on that scoop stretcher and all that. But you will at least have a C-collar on. I mean, they can clear you once they get on shore. That's up to them. But once it's initially put on out here, you're getting it taken off. Maintain or open the airway. We can use manual. We can use the head tilt chin lift, the jaw thrust. We can use adjuncts. We know that's the oral or nasal. And if you see any significant bleeding, we gotta fix that at some sort. We need to control it, figure out its source, suction it so it doesn't go down the airway or into the stomach. Because if that does that, they're going to vomit. I don't know about y'all, but I don't do vomit. We've already been over this. Had a guy in here yesterday, had vomited downstairs, come up here and he's like, very nauseous. I was like, hold up, bro. Here's my rules of the clinic. You don't throw up in here. And if you're sick, I got medications that I'm going to fix that. All I need to see is about 3 inches of your butt, and we're going to fix this. He slept really good, I can tell you that. I gave him a lot. So, but remember, suction that blood out on their facial issues. So interventions. If I do anything and during my assessment and on the way to the hospital, I need to make sure they didn't move. Reassess them. Is it something that's going to make, if I did it and I applied it and I put that bandage on their forearm to control the bleeding, is it still working? Is it still holding? Or do I need to add more? Now, we don't take it off and apply more. We just add on top of it. If you can't get it to quit bleeding, just raise the arm. Let gravity help you. And you keep it up high and you work forward. You need to make sure you note that in your report that your bandage on the right forearm applied at 1900 and 1915 during reassessment and transportation to the hospital. Right forearm bandage was noted to be soaking the 4x4, and a secondary fourth layer of 4x4s were added to the area. And at that time, elevation was applied. So I elevated their arm above their heart for the rest of the duration of the transport. You noted, you checked it, you did something, and you tried to improve it, right? So moving forward. So it says, what is this? Emergency medical care. Treat soft injuries. The face and neck is the same as soft injuries elsewhere to the body. Assess life-threatenings, ABCs. Follow standard precautions. In the absence of life-threatening bleeding, the first step is to open and clear the airway. Yep, because if you don't do that, it's going to be a bad day for you because now you got to really work. Avoid moving the neck in the patient's suspected cervical spine injuries. So here's this. So if you get there and they're laid like this and they're having trouble breathing and you hear them gargling, you can realign one time. You can line it back straight, midline, head tilt, chin lift. If they start breathing on their own, that's where they have to stay. You have to hold it in place and try to split it, use a headbed, use something to keep their head. Now, again, if they come back to the normal resting position and they quit breathing, you're like, God dang, I have to fix it somehow. And you don't use duct tape on their forehead. It don't do good when you get into the hospital. They will pull your license because you use duct tape on a patient. So don't do that. Maybe something you have to request a rider to go with you, some attendant to help you. They may or may not know what's going on, but you're in charge. You got to tell them what to do. Control bleeding by applying direct pressure, which we know that, and everything is going to be, once you get there, it all needs to be sterile dressing. If you're on the way there and you hear it's a massive hemorrhage, you get there and there's like 14 shirts applied and they all work in the oil field and they're covered in grease. That's amazing, guys. Y'all did an awesome job. But we need to replace this so there's not an infection. Who knows what you'll see? It might be warranting a Snoopy Band-Aid by the time you get there. I have those out here for those reasons. So when you pull it off and you're like, bruh, you have a scratch. Stop acting like that. So do not so use roller gauze, 4x4s, 2x2s, ABD pads, trauma pads, anything that you need to apply direct pressure and secure it. Gauze, rolling gauze is really, really good. It holds a lot of things in place. You can wrap them and secure them, different tightness without having to go super tight all the way around. And so remember, when you're applying direct pressure, you're not trying to stop the pulse from that lower part of the region of the body. You're just trying to stop the bleeding. That's all you're trying to do. You're not saying, well, gotta apply a manual tourniquet. Hang on, boys. Because that's not where we're at. Just applying direct pressure. We'll apply secondary bandages if we need to. Then we'll elevate it. If that doesn't work, then we can apply a tourniquet later down the chain. Least invasive to most invasive. So anytime that you have skull fragments missing, if you're missing a section of the skull, or it is obviously has a skull fracture, but it's not open, you want to try to cover it and hold it in place. Because just think, if I'm right here and on the way, my hair is moving, or any type of vibration, the two pieces of skull fracture is going to be going two different ways. So when we do that, we don't want it to cause any more trauma to the skull and or bleeding. So that's why I say make sure you cover it, secure it. If it is an open skull fracture, or let's do open skull fracture. So if it's an open skull fracture, what you want to do is you want to pad it with 4x4s, cover it as fast as you can, because now you're starting to let things get in there. They may become septic. If you can keep it clean, the better off you are. Now, eye injuries. Let me get my wonderful little cup here. I actually keep several cups in the clinic. Because if you have a penetrating eye injury, you want to take I like styrofoam cups better. Poke a hole in the end of it, whatever size is the appropriate. This is it right here. I want to take and poke a hole. Oh, I just screwed that one up. I want to take and poke a hole with another pin, not the pin that's stuck in their eye, obviously. And then that way, so I can take it and tell the patient what you're going to do. Hey, Fred, I need you to close your eyes for me. Because remember, if you look left, you only look left with both eyes. You don't look left with one eye. If you do, you're pretty talented, and I'd like to see it just because it's weird. but cover whatever object is in their eye with the cup. Ask them to please leave their eyes closed at all times. Don't open your eye on the way to transport, because what I'm going to do is I'm going to cover both of your eyes with gauze. I'm going to secure this cup to your face, because what you're doing is you're stabilizing that piece in the eye. This piece right here is going to be stabilized, because if this is in the eye and they look left, that's going that way. Look up. So that's what's going to, and that's gross. I can promise you, I've seen it. I've actually seen a drill bit. It's very gross. So if you take and put your hand over their eye, that's fine until you can get it stabilized and cupped, and then you want them to close their eyes. Trust me, it's gross. For soft tissues around the mouth, cheek, bleeding inside the mouth, make sure you bandage it. If you can take 4x4s or gauze and stick inside the gum, like you do with the dentist, but you don't want to impede or any possibility chance that they swallow anything. So just remember, tell them, hey, open your mouth. If you have to drool, that's fine. Here's an M&S cup. I just don't want you to swallow anything. What's it say? Physicians can sometimes graft pieces of a volved skull back into the appropriate position. They can. I don't know how that works. I don't ever get to stick around that long and see what comes of it. If you're able to find any piece of the body at all, take it with you. Toes, fingers, skull, nose, ears, teeth. Tell your rookie to go get it. That's the easiest thing. Hey, go get that eye over there. They can't replace the eye because it's already out of the face. It's off the optical nerve. But he can get that and bring it with him. If the skull is still attached in a loose flap, place the flap back in position. So if they get scalped and it's laying back here, just lay it back down and wrap it up. And I mean, it's not one of those you want to walk up and be like, oh look, that's pretty cool. That's not cool for us to do that either. Eye injuries, we talked about that one. Showed you how to cover that. Talk about that. All right, so this one's pretty cool on how to irrigate the eye. If y'all would look at the picture, what that is right here is a nasal cannula. So what they're doing is holding the nasal cannula to where the oxygen delivery part drains into the eye. You take the other end, and you would cut it, depends on how long you want it. You can cut it, you can use a full tube. I like to cut it to where they're about 4 foot long. You take you a 10 cc syringe. You fill it up with normal saline or bottled, the normal saline in the bottle. And you just flush it really hard down the nasal cannula so it has some pressure to wash it out the eye. It's pretty cool. I mean, you can make them in the field. Any chemical exposure is the same way. If you really need some pressure, you can turn around and add, cut it down lower till about 2 foot, to where you're kind of pushing about yay far off their face, and it has some pressure to still flush the eye. It's just something we've learned in the fields before. Over time, we make our own stuff. Right there. So foreign bodies do make an abrasion, small incision in the eye. They will leave traces of their location around. So if they happen to get it out and they're still complaining of, my eye pain and all that, keep them, get their eyes closed all the way to the facility, go that route. And the doctor, we can do it here too. If we dye their eye, we can see a trace of the yellow fluorescein underneath the black light and be like, yes, there was something in your eye. I don't see it right this minute. You flip their eye, you wash it, but that's what we do out here. And the same thing they're going to do in the hospital. Foreign bodies may be impaled in the eye. In your world, on the street world, you can't mess with eyes. You're not going to use the loop. You're not going to use the fluorescein. You're not going to use any of that. The best thing that you can do is tell them to close their eye, and I'm going to transport you to the hospital because that has to be taken out by a physician. Most of the time you'll get an optometrist if they're on call or your hospital has it. If not, the physician's going to come in. They're going to Tell the nurse to flush the eye real well and walk away. They'll come back and check it later. So burns to the eye. So let's look at this one right here. So here's types of burn. You want to wash them out. I feel like this picture is where they're trying to drown them. They're like, I'm gonna open your eye, but I'm gonna hold your face in this bucket of water. I mean, I know what they're doing. They're trying to wash it out, but these are your best methods right here of flushing the eye. We have these Eyewash stations all over the facility. We have the showers too, the little instant pull chain showers. Because you want to flush for at least 15 minutes upon a burn to the eye. Well, this one says continuously for 20 minutes. You're gonna have to have somebody help you at this point to where you can help with them tending to the patient while you open their eye and flush their eye. It's a continuous 15 to 20 minutes. Yes, they can still breathe through it. They're probably going to have some other issues. You do want to try to open it up all the way to where it gets the conjunctivity all on the inside and then on the bottom. Don't use your finger to go back and forth in there because you may turn around and scratch it more. During a fire, the eyes will close to protect it from heat. Eyelids are frequently burned to reduce specialized care. Cover both eyes with a sterile dressing and moist. Anytime you have a injury, like a burn to the face, just remember it's a moist sterile dressing applied to the face and the eyes. Transport them to the hospital. Remember, look for the soot around the nose and the corners of the mouth because they're going to attract to the most moist areas of the nose and the mouth. So you'll see it in the corners and right on the tips of the. If you see any type of burning in the airway, rapidly call for a paramedic or a helicopter because their airway is probably going to close soon. Let's take 10 minutes, y'all. See y'all back at 12 after. We'll stop for just a few minutes and should come back and make sure everything's good to go. All right, give us just a second, y'all. We'll see y'all in a minute. Hey y'all, sorry about that. Kind of get back to some things real quick. I gotta remember what my thought process was. I was changed to patient mode for a second. All right. So if we talk about burns, any burns to the eye, you can have UV burns, laser burns, weld burns. They're going to be all painful, really painful. You have to be careful about superficial burns can result from ultraviolet rays. We talked about that. And prolonged exposure to like a sun lamp, tanning bed, anything like that, or reflected light um, from a bright or snow covering. So they can also get eye burns. So like you're outside skiing or you're outside working, and then the snow will actually burn it because it projects it back up. So that does hurt. Cover each eye with a sterile moist pad and an eye shield. You want to try to keep it, you want to moisten the eye. The eye may be dry or they've had that burn and it's taken the wetness out of there. So it's just kind of, like when you get a sunburn, you got to keep lotion on there to rehydrate it because it's just dried out. It's just not like it normally is when you get those burns. So if you have any types of laceration to the eye, maybe I've seen where they've been in a car wreck and the windshield came out and the top part of the eye up here was actually cut. The glass was not in the eye, but we ended up having like you could like take and move parts of the top part of the upper eye. It was kind of gross. Again, apply moist sterile dressing to it. The more they move their eye, the more it's going to be. So it's easier to close that eye, keep it closed with a hand, a 4x4, something that would, you don't want to put the patient or your hand because now you're attached to them and you can't move away. So applying soft dressing, cover it, wrap it, keep it moist. I wouldn't say like pour water on the dressing itself, but take your 4x4, pour some water on there, and then wrap it with some gauze and all that to their face. Go to the next slide. Yeah, if the eye ever comes displaced, it's one of those that we don't want to try to replace it. We don't want to try to move it that one time. We just want to keep it in place, cover it, try to keep it sterilized if you can, keep it moist. The patient's going to be freaking out a lot. So try to keep them as calm as possible. It's probably going to be very difficult to do because of time, place, and location, because of what's happening. So be cautious of that. So calming them down to the fun part. If you have blunt trauma to the face, you may notice some redness to the eye because it may be because of bleeding to the anterior of the eye if they've had massive trauma. You may have a orbital blowout because of blunt force trauma. You can protect the injured eye with material. We know that. We talked about the cup. Some services do have the little metal retina cup, the little protective metal piece. It's got holes all in it, and it's like, I don't know what that's gonna do because you're gonna cover it, but it keeps anything else from getting into the eye. You can they say sports injuries cause a lot of retinal detachment, and I guess that's from concussions from being struck, hard hits, football, soccer, stuff like that. It's I don't know if many. You don't even really hear about that in the NFL. You hear a lot of that from like contact sports, MMA, boxing, karate, stuff like that. You may hear of those because of those rapid blunt force. Ever heard how easy it is? That would be a Rebecca question. I'm gonna call on the specialist there, Rebecca. Yo, girl, where you at? Key in right here.
Oh yeah, pugs, Pekingese. What was another one that I seen? I can't remember. Cats. As far as cats, a Himalayan, Persian, anything has real buggy, bulgy eyes, real easy to come out.
Yeah, their skull is so messed up. It's hard to slam on the brakes. I don't doubt that. I mean, I can kind of see that, and they already sit right there on the edge anyway. So there's not much orbital structure that's going to hold them in place. They probably sit right there on the edge. So poor things, though. I'm surprised they don't have like respiratory failure all the time because I can't deal with it. I know they're cute animals, but
some of them do, especially when they're fat.
Yeah. See, no, cause they feel like I need to tube them just to help them out. So hypnemia occurs when all part of the eye. An orbited fracture is a fracture of the bones that form from eye floor to support of the globe. Bone fragments can entrap in some of the muscles that control the eye movements. Protect the injured eye with metal shield. We know we talked about that, and it doesn't have to be metal shield. That's just what is nationally approved. Is that shield? Those little boogers are expensive though. You gotta be careful too. And you don't get them back. They're like obviously it's a one timer, but be cautious for that. There you go. Shih Tzus are the other ones. See, we learning all sorts of things. Humans, animals, we got it. We learning it. We're gonna be them basics. Where's my curse? My brush. Eye injuries that normally follow from head injuries. I told y'all about the blown pupil. You may have one bigger than the other. You could potentially have both of them, and you're like, I don't know, is that normal size? So normally I tell you to gauge the pupils on a regular basis. A lot of your pen lights that they sell now for EMS and all that already have those pupils on there, the pupil gauge on there. So it can't do anything but help y'all. So y'all remember that. Get you one, use it, put your hands on it, and assess those pupils at all times. It's gonna, the eye, any injury to the eye is going to be gross. You can have a lot of bleeding. The eye can turn red from the bleeding in the back side of the eye. You may have some optical nerve issues to where the eyes may move in different directions. I'm not picking on anybody if that's a pre-existing issue, but that's could be a birth or a traumatic issue where they move in all different directions. The best thing that we can do is just reassure them and get them to keep their eyes closed. Tell them everything that's happening. Be over informative and keep their eyes closed so it doesn't cause any other issues. Blast injuries. So we talk about blast injuries because you remember you got your initial blast injury, your secondary, tertiary, and so it's the same thing with the eye. So you're gonna potentially get debris in there. You have your signs and symptoms. Management of injuries to the eye depends on what's wrong. If nothing's wrong, I ain't gotta manage it. If they're blind in an eye, maybe try to get them an attendant. If you're in a mass casualty and they're technically a green and they're a walking wounded, get them an attendant if they don't have a family member there, if they're there by themselves. Try to find an attendant that is okay with it and of the same sex. It just helps a little bit so they feel a little bit more comfortable and they can walk them and talk them through the process so they can get to the end phase of it. Contact lenses, if at all possible, there's any injury to the eye, remove that contact the best as possible. Now, it is nice of us to try to put that contact in its container to where they can potentially use it later, but I don't really care. I need to make sure the eye is safe. Here's you a picture on how to find, now I don't know where that cute little contact thing holder in picture A is, but if you're able to locate it and you can put it in its original container, that's fine, so they can have it later. That's super cool of you, super nice, but the best thing is just to get it out. Get it out. You can, if you lay it out long enough, it's going to dry out, so that may be a end goal problem, but I'm pretty sure their insurance would place the contact. There's an issue like that. Nosebleeds, man, we talked about nosebleeds before. We know we want to squeeze it and point to the lean towards the front. Trying to figure out that picture. So I'm just gonna read it. It says the nose has 2 chambers divided by the septum. Each chamber is composed of layers of bone called turbines. All those above nose and frontal sinuses. I'm assuming this is the nose. That's the tooth right there. I'm assuming. Your nasal passage is not that big, y'all. Okay, so let's know that you don't have like 3 inches of nasal passage. That's just not there. But so you do have these. They're very a lot smaller. I'll tell you this again. I've told you before, when you get COVID tested, and it is a PCR only, not a rapid test. The PCR has to go back here and it tests in this area. That's why it's so painful. Causes all the tears. Here you can see your septum right here in the overview. You want to try to make sure that there's some stability, some rigidity into the nose. If it's been broken or fractured, obviously we can't do a whole lot there, but just don't let them swallow that blood. If you have cerebral spine fluid, it may escape down through the nose and fall in fracture to the base of the skull, and that could be also mandible fracture. Really have an open inside the palate of the mouth. Yes, you can get to the base of the skull that way. It is not common. If you're able to control the bleeding that way, maybe sterile dressing, let them hold it, stick it up in there, pull it out. Don't let them just hold their mouth full of sterile gauze. For a non-traumatic patient is bleeding from the nose, place the patient in a sitting position, lean them forward, pinch the nostrils. Remember, when it is time to remove those the gauze, don't just pull it out like that, because you want to slowly try to get that clot. It's going to be nasty, and contain it all and try to throw it away. If that's not the case and it does start bleeding again, just replace it with some new one. But you want to hold it with firm pressure for about 10 or 15 minutes before you try to move it. So we'll talk a little bit about the ear. The ear is divided into 3 initial parts: the external, middle, and internal ear. As you can see in this picture, it breaks it down to you as in the outer, middle, and inner. Here's your tympanic membrane. That is your eardrum. The ear canal is right in here. So I was right. So the pinna is also, that's where the cute little hook, ring, whatever you want to call it, goes up in here. And I want to say, forgot where I was talking about the other piercing. But I don't really know about all these. You don't see these a whole lot. You're not going to assess that into the EMS world. You don't have all the scopes and everything that look like that. We just don't have those, and it's not feasible to tell you to look in there. But here's the different parts of the inner ear, outer ear, and the middle ear. So you just know what particular bones, because this is the bones right here for the ear part. All this is cartilage. That's the reason why, like, if you have your MMA fighters, they get all that wrestler's ear, and it looks like crap. As you can tell, I'm not a wrestler. I'm just not in shape for that. So inner ear troubles, if you have your eardrums busted, will be very painful. I've done it 4 times. So you can tell on that. So what's it say? Ears are often, they do bleed. It's the same thing as a forehead wound, a facial wound. They're going to bleed a lot. It is. I mean, you can bend your ears and squeeze it and all that. So when you apply pressure, they may not be able to hear as well. So just remember when you go to do that you're not going to turn them this way so the blood doesn't go in the ear. It's just, you may have some blood coming from the ear. Just make sure you swipe it to begin with, and make sure you don't have the cerebrospinal fluid on there, to make sure it doesn't form that star or the circle, sorry, the halo, that you don't want that. In case the ear avulsion, wrap the avulsed part in the most sterile dressing and take it with you with the patient's name on there. Pretty sure if you had one dude missing an ear, you wouldn't try to sew it on somebody else's, but it has happened. Sudden change in pressure can create a blast, like a blast injury, an explosion, losing the hearing in your ear. Been there, done that. Patients will report severe pain, difficulty hearing, or ringing in the affected ear for hours on end. That last statement is hours on end and days. You hear the ringing. I heard ringing for about 6, 7 days. It come and go for about 4 weeks. So sucks. So at the same time, kids may affect their tympanic membrane, their eardrum by sticking stuff in there. They're like, oh, what is this? And it goes in there and it can bust the eardrum. We try to teach them not to stick things in their ears at a young age. All foreign bodies should be removed by a physician. But a lot of times, if you like the quarters, the ears, the P's, the whatever they are, they're gonna probably be there and for a while, especially the quarters and the nose. And if it's in an orifice, kids are gonna try to fit it there, see if it works. Remember, if you do have the clear fluid coming from the ear, it could be from a blunt force trauma injury or a trauma period or child abuse or anything like that. So check those fluids. Obviously, if they're soaking wet, it could be water. Let's think about that too. I don't automatically assume that they've been abused. Facial fractures, this will tell you is a result of a blunt impact. Could be from a result of an MVC, MVA, a fight, a slip, trip, and fall. So on these, you're gonna notice more of the inability to slow, to swallow, to talk. Things are not gonna be there. Teeth may be missing. It's hard for them to open their mouth because it's a fracture somewhere in here. And the hinge may be injured also on either side. So you'll hear a lot of popping when they do it. Let's see, facial fractures alone are not less an emergency unless they are serious. In addition to hemorrhages, there is a danger for blood clots lodging in the upper airway, causing an obstruction. Plastic surgeons can repair the damage to the face and mouth if the injuries are treated with 7 to 10 days. I tell you what, I can't watch the plastic surgery on the face. Like when they do like the nasal reconstruction, cause not happening. Don't want to watch it. If you happen to have any teeth, try to remove and save those teeth. You can potentially have them replanted. Remove any loose dentures. Always remove the dentures because specifically during CPR or if once a paramedic gets there and they go to intubate this patient, they could potentially break the dentures off, especially these two right here when they go to intubate because they apply some pressure to the upper jaw, move the jaw out, and they'll pop them loose. So if you know their dentures, see if you can get them out of the way. And make sure you transport those with the patient too, because you don't want to leave those behind. They're very expensive. Another source of airway obstruction is swelling. That's the reason why I tell you blast injuries, fires, traumatic injuries, you have to intubate and intubate fast, because once you start causing damage to the airway by the paramedic that's dicking around and can't get that tube initially on the first time, they're going to cause scarring, which is not going to be like scar, but they're going to cause that traumatic area, and the area is going to want to react to it, and it's going to swell. So we have to get that and intubate and bandage fast so their airway is secure. The airway can squeeze around the tube. It's not going to cut those tubes off because they're pretty thick plastic, but we want to secure that airway faster than anything. Dental injuries, if they're broken off and the root does not come out, obviously it's going to be painful because you'll have your nerve ending that's going to be out and dangling. You can touch it. I've seen that once or twice out here in the old field. They get struck in the mouth and you can actually see the nerve. It's kind of like an angel hair. This is the best way to put it. Doesn't look like it's supposed to be there. The first one, I didn't know what it was. I went to touch it. I was like, oh God, that's your nerve, because he jerked and about scared the hell out of me. If the whole entire root has been removed, make sure you just keep it sterile and wet, and transport it with you. If there's a lot of bleeding, let them bite on some gauze, let them hold that direct pressure. Cracked or loosened teeth, it potentially can be an airway obstruction, but it's got to come out. I mean, if they're awake enough and alert, tell them, hey, if you happen to feel this come out anymore, please spit it out for me. Let's spit that out in this container that I have laying right here for you. So just remind them to be mindful of that. We talked about that. Okay, so if you come in contact with something impaled in the cheek and you're unable to control the bleeding, or it compromises their airway, that's the only time you can remove it, is if it's in the cheek. Apply direct pressures the best you can, inside and out. Stick your fingers on the inside of the gum, separate it from the teeth so they don't bite your fingers. The amount of bandage should not be, massive. You're not trying to stuff their airway full, their mouth full. There's not a lot of blood vessels in the cheeks. I mean, you can see some other countries, some different religions, some different organizations. They'll pierce their cheeks. They'll put metal objects through there. It doesn't bleed a whole lot. They say that it's not painful. Not gonna find out. I mean, I got fat cheeks. I'm gonna keep my fat cheeks. So just remember, if it's impaled in there and it needs to be moved, you still need to try to cover that area and control any part of the bleeding. Remember, if you have damage to the trauma to the neck, you want to try your best and make sure that that airway is not occluded. Make sure that their necks are also taken care of, and I do mean by seat collars, manual stabilization, and that again, we just want to make sure it's in line, that it is straight up and down. The nose is in the center part of the body. You look for the Adam's apple, or look for the larynx, and make sure it's not deviated to either side. If it's deviated one side or the other, it could mean that there's a shift because of pneumothorax, or pneumohemo, or that they have a midline shift and something massive is going on that none of us can fix out here. Any crushing in the upper airway, the neck, is likely to involve a larynx or trachea, and it could be like a bat. We see these in baseball all the time, that younger kids get the bat to the chest and or to the face because they jerk and it hit them right there and it'll crush it. Signs and symptoms include loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, leaking into the soft tissues around the neck. You can have subcutaneous emphysema. And subcutaneous emphysema, if you're doing your assessment and you feel it, and it literally feels like like the Rice Krispies sound when you wet them, and it feels that's what it feels like. So that lets you know that there's subcutaneous air in there that has gotten between. It's basically in the fatty part of your skin. I don't know how many deer hunters you are in this group, but you can see subcutaneous emphysema a lot in deer after they've been shot, or any type of animal if they've been shot or anything like that. For hunting purposes, that you can see those. That's where I relate to it. I have a video of it somewhere, that after one that I show, it was a pig, and it was very educational at the same time. Yes, it is bloody, but it was pretty neat. The guy who taught us that, we actually ended up saving the pig. It was part of the school I was in. We wounded it. They didn't have to stay alive for the next 12 hours. It was pretty cool. So management of this, always consider any type of airway issues that you just don't feel comfortable with, that you're going to reach out and call for ALS support. That is a big thing, is to know your limit, know where you need to say, hey, I need some assistance, guys. Call for ALS support anytime. And I even do this during cardiac arrest. I put my patient in a spinal mobilization. I use my C-collar. Not saying I put them on a backboard, but it's pretty easy way to transport them then if they're cardiac arrest. But always use that C-collar. If you suspect any type of neck trauma, use it. Let somebody else that's higher than you or has better equipment at the facility to take it off, or rule the airways to be clear. It's the easiest thing to do. Penetrating trauma, we know that that's going to cause excessive bleeding, because if it's in the head and neck, we know that's very venous, has lots of vessels through there, so it's going to bleed. Injuries to the cricoid or jugular veins in the neck can cause body to bleed out. It can bleed a lot. If vein has been punctured in the air embolism, Yeah, stand by. Let me see if I can find this this video I saw today on Instagram. It's a guy, so his cricoid artery. So I don't know if y'all can see that, bruh. Like that's crazy. Like something's got to be wrong with him. I hope y'all can see that. I hope y'all can. I don't know. Can somebody just say put a wire in?
Yeah, I can see it.
So that so y'all can imagine like that's insane. That's the worst like I've ever seen. And then I mean, to me, instantly that tells me that he's got a lot of inner thoracic pressure because you don't normally see him that big. I mean, I can promise you that's. Whew. So the airway and esophagus and the spinal cord can be damaged by a penetrating object. We know anything can be penetrating can cause massive trauma damage. We know that. So direct pressure, always consider of internal bleeding to certain injuries. If it's penetrating, blunt force trauma, think smart and what organ and or body structure is behind that area. What, and I want to go 4 inches above, 4 inches below. That gives me a very good idea, and then go back to the anterior of the body. What's there and what can possibly be damaged. If it's a big cavity, always suspect that they have internal bleeding. Double, triple, quadruple, check their blood pressure all the time and notice those different changes. If you have a large grasp area change, you can potentially think that they are bleeding out. Assess the signs of shock, initiate spinal mobilization, restriction if indicated, and apply high flow O2. Again, y'all, high flow O2 is free, it's cheap to us. It's very accessible. Use it and just give it in the beginning so when maybe you can help curve that respiratory depression. And they're already getting that high flow of oxygen that you applied on the initial contact, and it was potentially can help you in the long run. Laryngeal injuries, blunt force, understrained driver strikes the steering wheel. We talked about that earlier. The larynx becomes crushed against the cervical spine, resulting in a soft tissue injury, fractures, and the separation of the fascia. These strangulation injuries can be found in either intentional or unintentional hangings. Anytime there is a suspected injury to the larynx, suspect possible cervical spine injury. Because you have, if you take a hanging and you do that little bit of stretching, you can have that all set. So you're going to have spinal cord issues. You're going to have a fracture to the airway, and you're going to have soft tissue injuries. So it's just basically like a blunt force trauma that's affecting there. So any type of hanging, unintentional or intentional, and you are able to get there in time and you're able to work this person, use a C-collar. It's very wise to use those. Penetrating impaled objects and larynx should not move at all unless they interfere with your CPR or your breathing. Stabilize all impacted injuries. If they're impacted, impaled, leave them where they are. Try your best to stabilize where it's at. Make sure that the piece is small enough that it can be transported inside your ambulance. You've seen some places to where they've had to cut the metal tube to get the patient inside. I don't know if y'all seen the pictures and videos of where a couple of soldiers have had heads of RPGs impaled to their body. That's probably can't imagine what they felt. But stabilize it enough to where you can transport them safely. If you're just like, oh my God, I need some help, call the cavalry, because that's something we don't see all the time to where you're like, that's like a 6-foot pole, bro. I don't know how am I going to do? What you want me to do with that? Obviously, it's going to have to be secured, reduced in size, but you got to control the vibration, the heat, all that stuff if they have to reduce the size of the pole. So ponder that, and that's your responsibility. Overall patient care, but if you don't like it, don't allow it to happen. Significant injuries to the larynx pose an immediate risk of airway compromise because it's just going to close it. If there's damage to the larynx and here's the spine, according to all that, all it's going to do is close it, and now you're going to have more issues because you don't have a passage for the air to go. Any type that you have larynx or traumatic injuries, you should have ALS, and they should be intubated early and sedated to where that they can be intubated and moved for safer care. So remember, any type that you go to a hanging, call for assistance early. Some signs and symptoms you can see of the larynx injuries. You see it on your screen. I'm not going to read those. I would pretty much sure you're going to have difficulty swallowing and a lot of pain. Those are pretty common. Signs and symptoms continue: subcutaneous emphysema, bruising to the neck of any sort of pine. You may see the mark, the ligatures where the blood has seeped into some of the smaller structures in the neck. Subcutaneous emphysema, we talked about that. Provide oxygen the best we can do. Apply cervical C-spine. Make sure when you do it, you don't want to use you remember the money collars I was telling you about, the tan ones? Those are more of what you want to use versus a regular C-collar to go from a car wreck. If you don't have those, what you want to try to do is use some rolled up towels. So your towels are you have more of an ability to stabilize it in the best position. So roll those towels up and put them around the neck. Keep the neck from doing this or that. So you want to try to put one in the back, the two sides. You don't ever want to cover up the center part of the larynx. And if y'all remember and look at C-collars, why is there a hole right here to where you can see their larynx? Anybody want to guess?
In case they need a trach.
Well, I can see it. I gotta keep attention. I gotta keep watching it. So you gotta manage it. You gotta see it. You gotta keep eyes on it. That's why. As long as it's there. And sometimes in those money collars, they have holes in them too. That's it. End of it. The next slide is the passcode. I know I've told a couple of you guys this, but please, I think I'm on the right track. And Joseph's mainly for you too. I think I have the issues fixed with the test of not producing a score. I've been on the phone a lot of time today about with JB Learning. I've tried, we don't know why. I've provided y'all's emails, the ones that I know that's had issues with that, so they can look at your particular section. So if it did not fix it, or y'all noticed it when you, for a little while, I mean, we're almost done with the whole chat, with the whole course, but take pictures of your final grade from your chapter test. If it does not populate it, please let me know and send it to me, or send me a picture so I can go in there and manually adjust it. We've had issues with Joseph doing it. I got it fixed, but I don't know. I don't know. So we're still working with JB Learning on that. I don't know why it changed out of the middle of nowhere. It did it on its own. So Joseph specifically, if you noticed that, please let me know. But I know I provided yours and another student's email address to keep an eye on.
All right, man. I appreciate it. I'll let you know.
Sorry, I was trying to work on it, but I was waiting on JB Learning on that part. Does anybody have any questions tonight? I think a lot of this was just kind of going over of some other, like a smaller course of what we touched prior to this. So does anybody have any questions or anything y'all want to talk about? Oh, on that. We just had a pretty big, I don't know what you want to call it, a little tutorial on FISDAP. I'm going to try tomorrow to email that out to you guys. I will send it out in a big email to the whole group. It's a video when Rob set through the class. So you may, if you hear Rob's talking, and that's probably it's why. But ours, we didn't record ours when we went to it the other day. So I will send out that tomorrow. So if anybody has trouble accessing that, please let me know. And if not, if you do, I will try to add it into JB Learning as a link that y'all can go and watch that. So that's the big things that I have to tell y'all guys. There you are. There's your class code for the night. 17-496 exclamation mark. There's your class code. Guys, good luck to y'all. Good night. We'll see y'all Thursday. And then I travel home Tuesday. So we'll see each other again on Tuesday night. But other than that, y'all enjoy your night. Have a good one. And I will see y'all Thursday. If you need me, I'll just have my screen off and my mic muted. So give me just a second.
All right, man. Take care. See you Thursday.
See you, bud. Be safe.